Now it is my pleasure to introduce our keynote speakers, Matt Hawks, Chief Operating Officer at Sanford Health, Nathan Peterson, Sanford Health's Chief Strategy and Development Officer, and John Snyder, President of Sanford Health Plan. Our speakers will be sharing insights and lessons learned from Sanford Health's initiative to improve access to affordable, high quality healthcare for their rural communities. Please welcome Matt, Nathan, and John.
Thanks so much. Well, welcome everyone. We're very excited that you've decided to spend the next 30 minutes or so with us to hear a bit more about Sanford Health's experience caring for patients and serving our health plan members in what is predominantly a rural geography, but with an eye towards value-based healthcare. Before we get into it, I want to start out with a special thank you to Fawn Lopez, the publisher at Modern Healthcare, and the entire Modern Healthcare team for the opportunity to be with you all today. Really appreciate this opportunity. So as we get set to begin today's discussion, I want to start out by introducing the gentleman that I've got the pleasure to be with today. Now, before we do that, my name is Nathan Peterson. I'm the Executive Vice President and Chief Development and Strategy Officer for Sanford Health. I'm joined first by John Snyder, who's the President and CEO of Sanford Health Plan. John's been with Sanford a little over 3 years now, leading our health plan. And prior to that, he spent a number of years at Carle Clinic in a variety of executive leadership positions, leading both operations as well as the health plan for that system. I'm also joined by Matt Hawks, who's the Executive Vice President and Chief Operating Officer at Sanford Health. Matt's been with Sanford over 18 years. He actually got his start while he was in college as a nurse aide at our medical center in Vermillion, South Dakota. Since then, over nearly 2 decades, he's had a variety of positions leading operations throughout the system and currently serves as our top operator today. Thank you both for being with us today and look forward to the discussion.
Thanks, Nathan.
Thank you, Nathan.
All right, well, to get things started, first I think it'd be useful if we acquainted our audience to our health system. So wondering, maybe Matt, if you take it first, if you might talk a little bit about Sanford Health as a health system and the care delivery elements of what we do that you oversee.
Sure, thanks, Nathan. I think easiest to start with geography. If you think of western Minnesota, all of North Dakota, South Dakota, and kind of northwest Iowa, and northeast Nebraska, that really is our footprint that we serve. We have the privilege to have over almost 50,000 employees as part of our health system that come to work every day, with their goal to dedicate their time and effort to providing the best care possible to our patients. We have almost 1,600 physicians that are employed throughout the system, over 1,000 advanced practice providers, which are nurse practitioners or PAs predominantly, physician assistants. And we have what I'll call regional leadership teams. So if you think about Bismarck, North Dakota, Bemidji, Minnesota, Fargo, North Dakota, and Sioux Falls, South Dakota, those are our 4 main hubs. And I think the secret sauce to all of that is we work as one system. So those leadership teams work together on a daily basis, always looking at what's the best for our patient, how do we provide the best experience, the best outcome, how do we marshal all of our assets in the organization, including assets in research, assets in the health plan, to make sure that our patients are receiving the best care possible at all times.
No, that's great. Thanks, Matt. And John, maybe from your perspective, just a little bit about the health plan.
Sure. Thanks, Nathan. So Sanford Health Plan is a very typical provider-owned health plan, but in a very atypical footprint. We're very much within the footprint of Sanford and really provide, I call it affordable yet sustainable coverage for our members and patients of Sanford. We have about 200,000 members. We do offer coverage within that broad multi-state footprint that Matt just talked about. We also are a 4.5-star health plan with NCQA, which really puts us in the top decile of other health plans across the country.
No, that's great. And I like you both remarked on the footprint that we serve, whether it's care delivery, insurance, and some of the other ancillary services that we have. And I think it's worth reflecting on how that's fairly unique. When we track our data on an annual basis and we look at the patients that we serve, more than 2/3 of them come from communities with a population of less than 50,000. And it's a similar issue with the health plan where over half of our members reside in rural communities as well. And as we go through that, I think we experience on a daily basis what some of the literature would suggest, which is when you're working with a more rural population, they tend to be older, they tend to be sicker, they have some unique challenges when it comes to accessing care. They probably have fewer options relative to their health insurance. So I know as a system, working with your leadership in both of the teams, we've really made a commitment to our communities to help overcome some of those barriers. We certainly saw many of those challenges exacerbated during COVID-19, so I think that added further emphasis for us on how we really need to step up and make sure that we're caring for those communities and meeting them where they're at versus having them conform to how we'd like to offer those services.
There's a misconception that in order to be world class, you need to perform on the world stage. But sometimes being the best just means doing things the right way, right where you are, because it's the right thing to do. We believe you deserve world-class health care no matter where in the world you live, because every patient, everywhere, means the world to us. Here for all, here for good. Sanford Health.
So we acknowledge there's some unique challenges delivering care, offering insurance in the communities that we operate in. At the same time, we've made that bold commitment that we're going to ensure that no matter where you live, you have access to the same quality of care, the same services that you could find anywhere in the country. I'd love to have you talk a little bit about how you see some of those unique challenges influence the elements of the system that you lead, and how are we using integration to help overcome some of those? And Matt, maybe I'll start with you on that question.
Yeah, I think those challenges are alive and well in every discussion that we have, and I think when you think about that aspirational goal of, regardless of your zip code, you should be afforded the same level of care. I think about a couple of different elements. One being, trauma. What happens if you're in a rural community and have a traumatic experience, and how are we going to make sure that if you enter one of our critical access hospitals, you have the same level of care? And that's a very difficult challenge to overcome. So while that patient is being cared for, through that connectivity back to one of our trauma centers, we also have the ability to dispatch one of our assets through our air medical teams. We have 10 aircraft, air medical transport that includes King Airs and helicopters throughout our system to make sure that we can extract that patient and get them back to one of our trauma centers in a timely fashion so that we can compress that time away from the care that's really needed. And so that obviously is a key element for us, and how do we bridge that gap from geography standpoint to make sure that that level of care is being delivered regardless of the zip code.
That's great, thanks Matt. John, typically smaller spread out populations is not the first choice for a health insurance company. Just curious how you've approached that population and meeting their insurance needs.
So obviously we need to take advantage of our core asset, which is being part of a system. And that gives us advantages in that we can have a very thorough and complete network of providers for members to see. We can leverage virtual opportunities for patients. When I think about how do we uniquely serve this different rural population, I think a great example is how we handle prior authorizations. So prior authorizations are a way that insurance companies, from a utilization management perspective, ensure the appropriate therapies being used. A lot of times insurance companies use this as a way to control costs, to be honest. At Sanford, what we do is we leverage the fact that we're a system. And so we're able to do some of that prior authorization kind of behind the scenes, so patients don't have to get involved in that. It's minimal impact to providers. And more important, as you think about a rural setting, you just think about someone who goes to see their physician. They drove an hour, maybe 2 hours, right? And they're there and they could go ahead and have that therapy or that treatment right there and not have to come back. Well, if they have to go through a traditional prior authorization process, they would have to come back. With us, we're able to, a lot of times, not always, but a lot of times streamline that, and you just get all the care right there. And that's just a great example of how we're able to adapt to our rural environment.
Oh, absolutely.
I think a real life example of that, and it was a real proud moment for me in working with the health plan and John and his team, was, there's a lot of prior authorizations around high-end imaging. And we have a group of radiologists among our system of almost 60. Highly specialized radiologists, and for them to get around a table with the health plan and come up with best practice guidelines as it relates to high-end imaging, and that kind of in the background drives the behavior of our physicians because best practice alerts pop up, and will navigate them away from a CT to maybe an MRI or vice versa, and that the health plan trusted us to create those guidelines to meet that same need of a prior authorization. It's not to deny care, it's to make sure they're getting the right level of care. And I think working with the health plan in that way really is a symbiotic relationship that takes away a lot of the waste in our in most organizations of prior authorizations, because prior authorizations, it takes a lot of time and effort. And if you can eliminate that by going right to the physician group and saying, what is the best way to handle a patient like this, and then how do you spread that, embed that as a guideline or a protocol within your EMR, then the health plan trusts that we're doing the right thing for the patient, which is obviously in the best interest of the health plan and the health system and the patient.
Right.
Yeah.
I just add to that, I mean, again, being part of a system really allows us to approach it, because we're provider-centric, right, and patient-centric. And it really allows us to approach it in a very different way. So our chief medical officer is actually a Sanford physician, practiced at Sanford full-time before. And we don't look, a lot of health plans look for denial rates. They kind of benchmark it. They look for a 10% denial rate. That's kind of a benchmark they look for. I would flip it around, and we're able to do that in that we're looking for a best practice rate. I want a 90-95% best practice rate. And we can use our chief medical officer, who's a colleague of the physicians, rank and file physicians at Sanford, to work through, as Matt talked about, those best practices. And it not only helps our Sanford patients, but it also helps us to take that to non-Sanford providers and say, we've worked through this. This is best practice. This isn't just something we pulled out of a book, and it makes a big difference.
Well, it seems to be a great example of what everyone's after in value-based healthcare. It's a way to standardize towards quality improvement. It's a more efficient way to deliver the care. And at the end of the day, it's a patient or member satisfier if they don't have to make a second trip in for the subsequent service that they need. I think that's fantastic. So there's an often cited statistic that an individual's health outcome is 10 to 20% determined by their medical care. And the rest of it is determined by their behavior, their genetics, their environment, et cetera. With that in mind, I think we've accepted sort of the obligation and the opportunity that if we're going to advance value-based care, we've got to move outside the walls of our facilities and sort of beyond the list of covered benefits that we offer to folks. And so I think with those things in mind, I'm curious to hear how you think population health plays a role in advancing value-based care at Sanford.
It absolutely plays a huge role at Sanford Health, and I think it starts with our people first. How do we make sure that we're taking care of our almost 50,000 loved ones, part of the Sanford family? And we realized, thanks to a partnership with the health plan and some of the statistics that were coming through with our group health, which is our employees' insurance product through our health plan, some of the utilization, the rising risk, and how do we address this before it becomes a bigger problem for us? And that's the whole goal of population health, is to make sure it's the right treatment at the right time in the right place, to prevent them from continuing down that path and being in a worse position, which nobody wins in that situation. And so with John's help and his team's help, we were able to identify a group of Sanford Health employees, part of our family, that were in that category, that rising risk category. And we asked the question, what can we do to come alongside them? How can we help shepherd them, through their journey and make sure that they are accessing care in the right way, that they have access to medications and other things, other social determinants of health that may be absent in their current situation. And so we started out on a pilot project that is just recently started, and we hired health guides. We created a curriculum for these health guides on how to work with patients to navigate a healthcare system. How do you navigate their community to look for resources to help overcome some of those social determinants that may be keeping them from optimal health. And we've seen a great response to that. So the 10 have been hired. These are non-licensed individuals. Like I said, they go through our own homegrown training program. And they're really there to help assist and navigate the patient through things like appointments. They go to appointments with patients. They call them regularly. They're checking in on them. They're looking at their EMR to understand, where have they been recently? Did they show up to their clinic? Have they been in the emergency department? Were they hospitalized? Are they now discharged? Do they have a follow-up appointment? All those things. And so those 10 individuals have a panel of 40 of our family that they work with on a daily basis. Typically, we can graduate those 40 people after about 6 months, and they're kind of on their own and maybe able to continue on that journey without the assistance. Within 6 months of implementation, we saw a 62% decline in ED visits, a 67% decline in inpatient admissions, and a 34% drop in the clinic no-show rate. So again, going back to the right type of care, the right time, the right place, we really feel that we really broke the code, so to speak, as it relates to population health, obviously, which drives value for everybody. But more importantly, it drives a better outcome, for one of our family members.
Absolutely. Well, with results like that, it sounds like something I'm sure we'd all be interested in scaling as quickly as possible, and probably bodes well for the health plan as well. John, just curious for your thoughts on the topic as well.
Yeah, we certainly approach population health as a system. And if you think about, on the provider side, the kind of care management assets are to some degree episodic, transition of care type things. From a health plan perspective, it is actually, more longitudinal. But if you think about it, if you're not coordinated, you step on each other's toes, you miss things, and we're really able to approach it as a system. Matt leads a population health kind of steering committee for the system, and it really allows us to make sure what we're learning from best practice. Health guides is one, that we're coordinated, and I think it makes a huge difference in our approach. Matt talks about the health guides. As we try to think about the social determinants of health, as you kind of talked about earlier, good examples are, finding transportation to go get your medications. These health guides can step in and do that. And those are the kind of things those statistics that Matt talked about that were so impressive. That's what drives those things. So we're able to utilize that. Or, for example, a diabetic who just doesn't have access to food. So the health guide can help them get to one of our food pantries that can help them get that access to food, which make all the difference in their outcomes. The other thing we've done kind of complementary to that, and we've started in our Medicare Advantage population, but we're going to expand it, is health navigators. And they're different than the health guides in that they're really there to help really navigate through a very complicated health system, which is that way all across the country. And again, in our unique rural footprint, as you talked about, it makes all the difference in the world sometimes.
Mm-hmm. Well, John, you mentioned food insecurity as one of the issues that we've got a close eye on. And I think that during the pandemic in particular, in some of the communities that we serve, we saw a sharp increase in the demand for food assistance as people were struggling with work from home, school from home, trying to wrap their arms around what we need to do together as communities to get through the pandemic. And as we saw that increase, we had an opportunity to partner with our area food banks in a new way. And as we made an additional contribution to help support their work, I was struck by the feedback that we received from each of them to a person saying that, this is going to be a huge help to increase the amount of food that we have to give out. But right now, our largest challenge is our distribution network. And are there ways that we can work together to expand that distribution network? And as we approach some of our clinics, I think we came up with a fairly novel solution that's really worked out well as we've now embedded food pantries in some of those locations. And Matt, I know a lot of your teams worked with identifying the locations for that and helping set that up, but just curious how you think that's worked out about a year and a half after it started.
I think it's a fantastic idea, and it doesn't always take a new strategy to solve a problem. So if you think about, a lot of our clinics are in remote locations, far away from our main medical centers, as well as some other infrastructure that surround our main medical centers, like durable medical equipment stores. And what we created a long time ago were what we call durable medical equipment closets. So it was a closet that was an extension of one of our offices in the clinic, so that if the patient needed a splint or a cast or something like that, they didn't have to jump in the car and drive 20 miles to get their splint. Obviously now, taking that same strategy and applying it to food, can we put food pantries in the same type of location, one of our clinics, so that when a patient comes in and we realize that they're in need of something to bridge the gap, that we're there for them on a Saturday morning or a Sunday evening or whatever it may be. So it was really kind of a nice way to take something that's worked before and apply it to a new problem.
It was a collaboration with the Great Plains Food Bank here in the community. Sanford has been donating to them over the past few years. And so it was just a great opportunity that we found here at the Southwest Children's Clinic for it to be a great need for our families and children in our community.
It's been wildly successful, which is it's very bittersweet overall. It's really great to be able to help these families if they're struggling, but it's really sad to see that there's such a great need in our community. It hasn't taken much as far as appointment time away from the providers, I don't think. The nurses are really quick and the transition with the questionnaire is smooth. So it's been really nice and really easy, and it's been very rewarding to be able to help families and see how appreciative they really are.
So as we think about some of these demands on health systems and some of the opportunities that we have to serve our patients and our members differently, provide them that extra layer of support when they need it, it feels like the scope of what we need to accomplish is really expanding. At the same time, I think that we've got some exciting new tools at our disposal to help us do that work. So I'd be curious to hear both of your thoughts about how we've been able to leverage data, technology, augmented intelligence, and the like to be able to support the work that we're now doing to deliver greater value to those we serve. And John, maybe I'll start with you on this one.
Sure. Well, again, as an integrated system, we have the luxury of having kind of claims data, but also clinical data and also social determinants of health data. Really, in all those three kind of inform how we should try to care manage patients and members. They help us decide where we need to intervene. For example, the health guide example we talked about, we call it the Sanford Severity Score Index, and it really helps us hone in on where to use our resources to have the biggest impact, not only on the provider side, but the health plan and how do we coordinate that. Another thing that we have done is use what we'll call digital enablers. And whether those are things that we can, whether it's an app or whatever, let the patients use. And if you think about how do you really move the dial on care management and population health, it's really getting patients engaged. We can care manage to the nth degree, but if they're not engaged, we're not going to move the dial. These digital enablers really help get patients engaged in their care and kind of own their own health, which is really the ultimate goal. Mm-hmm. So we've been able to do some of those things again because we are a system. We're able to leverage those resources to do that.
Absolutely. Matt, I imagine some of the same tools or similar tools that John mentioned are useful for our providers as well as they think about how to develop appropriate care plans and engage with patients. And just curious for your thoughts on this topic.
Yeah, I think, interestingly and timely as well. On the way over here, I got a phone call that we identified a suicidal patient through our chatbot technology. Mm. So just on Monday this week, we started pushing out to our patients the ability to connect with them through a chatbot to see how they're doing. They sign up for that service, and we started pushing out really a number of questions to these folks to see how they're doing from a mental health standpoint. And this individual earlier this morning started to answer these questions, which kicked into a depression screening, which then ended up being able to identify that he was suicidal and he had a plan to commit suicide. And that was averted less than 2 hours ago.
Oh my goodness.
And so it's just a really good way to point out how working with patients who are at high risk, patients who we know potentially have behavioral health concerns, how we can connect with them in a way outside of the traditional four walls of a clinic or a hospital or something like that. And it's just a really good example, and it just happened this morning.
It's a very, very powerful reminder. If I think back to our experience during the pandemic as well, and I remember in the days of incident command when we were anticipating release of the vaccine after the first was going to be approved. And we knew that at first there'd be a very limited supply and an outsized demand for the vaccine in the early days. Maybe talk a little bit about how we use some of the advanced analytics that we developed during the pandemic to help us prioritize how we distribute that vaccine to have maximum impact.
Yeah, it all started with a registry. So March of 2020, we all were sitting, everyone probably, if you're in healthcare, we're sitting in some type of conference room, either in person or virtually, trying to address the challenges that COVID was throwing at us. And as we started to do that, we knew we needed to get information. Data was going to be key for this, to learn and make sure that we could pivot quickly and stay ahead of it. Mm-hmm. So we started a data registry, which meant every patient that was diagnosed with COVID, outpatient or inpatient, that we were tracking information from that experience. And that fed a huge database for us. I think over 100,000 patients, if I recall correctly, about the time of the vaccine became available, had been entered into that registry. And we knew that the vaccine supply was going to be short of what the demand was. Mm-hmm. And knowing that our patients are looking to us to make sure that we're taking care of them. So they're looking at us to say, when's my vaccine ready? Which is a huge burden, but then a privilege as well. So what we did is to go back to that registry and say, all right, who are the patients that got COVID, that got admitted, and then had a bad outcome, right? I.e., were they on a ventilator? Were they in the ICU? Did they have some other condition that developed because of it? Did they pass away, unfortunately? And that started to create an algorithm for us, working with our data and analytics team and our clinical teams to say, here are our high-risk patients. They are the highest risk. If they get COVID, we know, that it's very, very likely that they're going to have an adverse outcome. And then what we started to do was start to message those patients to say, we've got your vaccine, come in and get it. But also at the same time, letting all of the rest of the patients know that you're important too. Your vaccine is coming, and when it's your time, we'll invite you in to get vaccinated. And I think that just speaks to how we use data and analytics to really take care of our patients, and act as a family, and not have it be a chaotic situation where nobody knows where to go, nobody knows who's looking out for them, who's got my vaccine. Once you're part of the Sanford family, you're in, and we're going to take care of you.
Oh, thanks, Matt. I think one more question I have before we move on to the next topic relates to kind of a unique initiative that we have at Sanford Health. In 2013, we were very fortunate to get a gift from our benefactor, Mr. Denny Sanford, that allowed us to establish a fairly unique program that integrates medical genomics and genetics into internal medicine and the primary care practice. And since then, we've been able to offer unique services to patients and generate a large amount of data. And Matt, I wonder if you'd maybe just reflect a little bit on that particular initiative and what it's allowed us to learn from, and how we've been able to serve people a little bit differently.
Yeah, like you mentioned, one element of that initiative is genetic screening. So we're screening for predetermined known disease-causing mutations that would alter a care pathway if you had one of those. And the other element for the screening is really around pharmacogenetics. Again, screening your genome to known mutations that are known to cause an individual to not be able to metabolize a medication correctly. And as we've done over 30,000 of these tests, we're coming to find that there's a lot of mutations out there, and there's a lot of drug-gene interactions that we're identifying. Luckily, a lot of these are preemptive. Like myself, I'm kind of a mutant. I don't metabolize anything well. But for instance, if I was to develop a heart condition and I need to be put on Plavix, a best practice alert would fire because I was screened, and they would go to an alternative drug because I cannot metabolize Plavix. And so we're seeing quite a bit of that preemptively and able to avoid those situations. One unique thing that we are doing with the health plan, again, it goes back to piloting things because we're an integrated health system. How do we take our group of employees, our family, and say we have this technology and let's try to apply it, and make an opportunity or a better outcome for one of our employees in their current situation. And so one of the things that we partner with the health plan is to look to our group health population, again, our employees, and screen for mutations known to have caused metabolization issues for SSRIs or antidepressants. And it's newly kicked off, and I think we're right around 140 patients in so far. And we're seeing traditionally folks, 87% of folks are actually on the right drug and doing reasonably well. But how do you get that up higher? And so through this program, we've now seen that number rise to 91%. And so we've seen a 4% increase with a small number of people. But I think what's important is 4% doesn't seem large. But if you go back and look, they estimate back in 2018-ish that about 13% of Americans are on an SSRI. That's over 40 million people. And if 4% of 40 million people can be helped through this technology, it's a great thing. It helps, obviously, the health plan. It helps us as a health system. These employees are in therapeutic range. They're coming to work. They're able to function, and not to mention their quality of life is, obviously hugely impacted. So, again, one way we're taking technology, applying it to our population in a pilot situation to hopefully overcome some of these issues that our people are facing, because not all drugs are alike and not all people are alike. And so how do you customize that and personalize and tailor that care in a way that works for them?
John, if I think about the ability to offer something that's fairly unique like genetic screening at a very affordable price point, just curious, how significant is that for a health plan's ability to advance value-based care for the people?
It's a great example, and if you think about a provider-owned health plan, it really is the opportunity to be innovative. because for a certain group of the population that we serve, we kind of control dollar one. We control the financing, so we can kind of get out of the bounds and do innovative things. Actually, this is one of the things that attracted me about Sanford when I came here. I learned about it, listened to Matt at Clinic Club before I came here. Sanford is really unique in how it does these kind of innovative things to really help. And I think it's a really great tool as we think about our unique rural population that we can use that and do that.
Mm-hmm. Oh, that's great. Well, maybe last topic that I think is worth exploring today is an exciting initiative that we were able to announce last year, again with the benefit of some philanthropic support from Mr. Sanford, of a new virtual care initiative or virtual care strategy. And I know that announcement didn't mark the first day that Sanford started thinking about virtual care delivery. It's something that we've been doing for a while in specific areas of the system. But I think that the new focus and the new investment on that is really going to allow us to catapult it into the future much more aggressively than we've maybe done historically. So Matt, I'll maybe start with you. If you'd be willing just to talk a little bit about what that strategy entails, what it'll allow us to do, and how we can address some of the challenges with it that we noted at the beginning of our presentation.
Yeah, I'd be remiss not to go back in time to probably almost a decade ago. Really virtual care was starting to get kicked off. And when I say virtual care, it's really the health system to the patient in their own home, connecting via telemedicine, video, audio, et cetera. And we sat down as a team. John hadn't been here yet, obviously, but the health plan team that was there, and we said, we're going to develop this technology, and we're going to make sure that our patients, if they want to connect virtually to a Sanford Health physician or clinician, that we're going to afford them that ability. That we don't want them going outside the system, we don't want them going into the ER. If they want something now, how do we develop an appropriate connectivity to them? And I think if you go back 10 years, every virtual care interaction was cash pay for patients, which for the most part was a deterrent, and people didn't access it because they didn't want to have to pay out of pocket. And I know that when we develop something as a health system, we want to make sure that our health plan knows what we're doing and comes with us on that journey. And I think the first conversation that we had, the health plan was all in, saying we're going to have this be a covered benefit, which is huge for our patients, especially in a rural community, like the rural communities we serve. And so kudos to the health plan for coming along and saying this is something we want. We don't want patients in the ER. We don't want patients going outside the system from a virtual standpoint. Continuity is important to us. And so it all started there almost 10 years ago. Now fast forward, and like you said, we have the opportunity to have a relationship with our benefactor, Mr. Sanford, who, as we put this business plan in front of him, this is another 10-year journey for us, where we knew over the next 10 years this is where we needed to be. But yet his help will accelerate that. And really the virtual care center will be a bricks and mortar building, obviously focused on caring for patients and caring for the patients that are in our facilities, in our clinics, and being supportive to the infrastructure that we have today of obviously our physician group and advanced practice providers, et cetera, clinical teams. So we are going to work obviously to create what I'll call a safety net, so to speak. So telemonitoring in the ICU, telemonitoring in the home, home monitoring, so that we can make sure that we know if a patient's condition is worsening, that technology can alert our physician group to let them know we need to intervene. We'll be doing investments into our behavioral health infrastructure. Our goal with virtual is that ultimately, in the not too distant future, that no patient would have to wait more than 24 hours if they wanted to connect with a with a behavioral health provider. And obviously virtual will be a huge bridge to get us there. We also will continue to develop other subspecialty and outreach. We will be looking at putting clinics in communities, and we will not be staffing them with a physician or a nurse practitioner or a physician's assistant, but rather we'll be staffing them with a physician, nurse practitioner, physician assistant virtually from the virtual care center. So we'll actually have a bricks and mortar clinic in a community, maybe the size of 2,000, population of 2,000. We'll have a nurse or a medical tech there. We'll have X-ray, we'll have ultrasound, and we're going to test this out. Can we be bringing primary care into communities that don't have it today? Again, bridging that geography gap that a lot of our communities have today. In addition to that, we'll continue to look to innovate around virtual delivery. What is the hospital bedroom of the future look like? What does the surgery room of the future look like? What is the clinic, the home, et cetera? And then also an initiative undertaking around education. This is something that we feel there's a gap there on how to educate not only our clinicians and the clinical teams to provide care virtually, but also what do the patients need to be educated on and how to use and interact with us virtually. So we're really lucky to be in the situation we are. Again, it's another investment to make sure that regardless of your zip code, you're being afforded access to the same level of care as if you were in a major metropolitan area.
Oh, that's great. John, Matt credits prior health plan leadership with injecting some early momentum into our virtual care efforts. As those capabilities and that technology really matures into the future, I'm sure it's a two-way street, and the health plan's reaping some of the reward as well. I'm just curious how you've been able to capitalize on those capabilities to advance service to the membership.
Right. Well, I think we talked about at the very beginning. I mean, we do have obviously our members are very, rural and where they live, and it's hard sometimes to reach them. And this just gives us an incredible tool to be able to reach them in a whole different way than we've historically been able to reach them. So I think in the future, as we develop capabilities in the virtual center, we'll be developing health plans that really, kind of encourage that kind of use and allow people to access care differently. One of the things that we're doing today, and I think we're probably one of the very first, kind of initiatives out of the Virtual Care Center, is really putting together what I'll call a virtual annual wellness clinic. So we have a big population of members who are in the federal marketplace, the exchange. And if you think about that membership, you kind of have two different main groups in that group. You have people, younger people generally, who are, it's a cheap way to buy insurance, and so that they go through that way. Then you also have people who have subsidies who buy insurance that way. And the common thread with both those populations, for the most part, they don't come in to see their doctor unless they're really sick or something's wrong. And the benefit of a virtual, visit, we can identify things proactively and get them into treatment before, it gets too far down the road. So we're implementing that. We're actually targeting almost 10,000 members that we're going to try to get that done this year. And I think it's very innovative, and we wouldn't be able to do it if we didn't have these virtual care center resources to do it.
That's great. Thanks, John. Well, thanks again, everyone, for joining us today. I also want to thank Matt and John for spending some time to visit about value-based healthcare today. We know it's an incredibly important topic and appreciate Modern Healthcare hosting this discussion. And again, our thanks to Fawn Lopez and your team for giving us this opportunity. I think it's safe to say that while we're excited about where the system's at and where healthcare is going, we still have a lot left to figure out. And so our commitment stands to continue finding new ways to advance value-based healthcare for the rural residents that we serve throughout our footprint. Thanks so much.